Bueno, pues ahí los tenéis, quien tenga dudas de todo lo que nos han explicado.
You've got them right there at the presiding table. If you do have any questions or tribulations or comments or remarks, just raise your hand. Please speak to the microphone. Otherwise, we cannot hear you in the sound of silence at the back of the room. Thank you. A very good morning. I am a surgeon. I am new in this forum. I have a grandchild with possible WD, and I really want to thank you for the information that you have shared with us. And I wanted to ask the following. There are two manifestations, one hepatic and the other one neurological, or can they be a combination? That's one question. Question number two is, if you have no clear diagnosis, should we think of any therapeutic measure, or should we wait until we have a diagnosis? Because it is a child, I'm going to give the floor to the good old pediatrician. Regarding the first question, if it's a combination or if it's separated, that is why when we talk about the neurological manifestation, we pretty much take for granted that we have something going on in the liver. When we do the fiber scan, when we do, so we know that we're going to find. It will be very rare that we don't find anything at hepatic level. Regarding the second question, we have many cases that we have done, and we start with a regime right there. It depends really of the severity of the manifestation, but really thanks to the diagnosis diagnostic methods that we have, we're definitely pretty much knowing right away if we are right or not, if we have a WD or not, and we have less and less suspicious cases or unclear cases. So I do understand then that first there's some manifestation, hepatic manifestations. What happens is that at the liver level, it could be asymptomatic, and now we're going into a transaminase increase. The children do not go through a transaminase increase, and sometimes when we see it leading towards progression, even in cirrhotic patients, it will be normal. And pretty much what he said, in neurological patients that usually you see later on the stage of the disease, it does not mean that the liver is not going to be affected, okay? And also the techniques that we have, for example, in Valencia, the exchangeable copper is made in Barcelona. It's a very, very good lab, and they will send you the results less than a week. Usually, what I do is I do the follow-up visit to the clinic 10 days, because that's enough. But if you tell them to do it, the first assessment, you could have it by the time you need it. It will not really delay you in the diagnostic process. And then you will have a... And the second, regarding diagnostic suspicion, should we start with a treatment regime, or should we wait to have a set diagnosis? I believe, I mean, it depends on the case. If you have Leipzig score 3 or above, and you have an increased hepatic enzyme, you could start treatment. But maybe wait for those 10 days or 1 month till you have the. Thank you so very much. Thank you all. Again, please raise your hand and wait for the microphone to be brought to you. Thank you. Can you hear me? Related to what Eduardo said and how difficult it is for children, we see some pharma companies here. We would love to have a syrup presentation, liquid presentation. Please, if we have any pharma company here, forget the tablets, forget because if you know, I had to pretty much give them water, honey, and then dissolve the pill in there. I had to crush it there. We do agree. We need to convince pharma companies. Anybody from pharma companies, please? Something we need to do. Where do we need to go or call? No, seriously, jokes aside, the presentation should be something that makes it easier for us. While they do a question here at the back of the room from the pediatrics, I get a lot of patients that is it only in Valencia, or is it because what you said, that sometimes you need to increase dosage because you know that after you crush them or dilute them or anything for the intake, you're just taking that into account? Well, it's very hard. It's very hard, even when you talk about times. It depends of each country. If you take a look at the questionnaire we have, we almost went away from dual therapy, dual treatment. We tried to see what we do, but I know that in some places it's really going to depend on what you want to do. When I get a patient with dual, I remove, but sometimes if I remove it, transaminase goes up, and then I say like, oops, I did something wrong. So I don't know if that is pretty much because pediatrics does it that way or not. Hello. We have 2 children. One has been diagnosed with Wilson. Genetic is enough in order to diagnose? No. If you do genetic testing, no, because there's a small percentage, because it depends. I think Carmen Espinos will touch upon that. But if you go to a super lab that they do all the super duper checks, normally 98% they will find something when it comes to lymphoma. They were made at La Paz. In La Paz Medical Center, it's a reference medical center. But there's always a percentage. I don't know. Maybe take that to Carmen, because well, thank you so very much. One in the middle of the room. Well, let me talk. Hello, very good morning. My question is, this exchangeable copper that we have talked about, which seems to be quite an interesting test, do you do that in all hospitals? No. Okay. And can you actually make a request for the reference center? Actually, they were doing it in the Hospital Clinic in Barcelona and in Madrid. Zoe, do you know? Ramón y Cajal in hospital. Yes, they are. And we also do it in the Basque Country in some hospitals, and in Madrid and in Barcelona, of course, we did it. But several centers have requested us for help. So we actually are training some hospitals in order for them to do it. So it shouldn't be a hurdle.
Just a question. Thank you, the three of you. Eduardo, could you please mention about the ceruloplasmin? It can be low physiologically in children at a very early ages. But my question, I'm sorry, the microphone is, there is cuts on the microphone. From what age should we be assessing ceruloplasmin, and does it condition the family screening? Well, a reference basically is based on literature, and what we try and do is we wait until the child is 3 years old, it's stabilized, and then we do this family screening. But I know some published cases when we have 1.5 years with some transaminase level, where we do this follow-up of transaminases, and when at 3 years we do the exchange copper and the transaminases and all the rest. Good morning. Well, I had some questions as well. My son is 7 years old and has been diagnosed with Wilson's disease, but my daughter is 3, and the gene analysis is basically the same as the one as DDAC. Transaminases and all the rest, all the tests are pretty normal, but they are telling us that most probably she will be diagnosed with the Wilson's in the future. Is this the case, or could it be that she's not going to have copper overload in the future? That's my first question. The second question is like we are using cupripren for my son. How do we decide if we are using Wiltrin, cupripren? What's the best drug? Are we just it's just a test? Do we have one drug that is superior to the rest? Well, I'm not sure if we have understood the second question. Yes, the second brother, 3 years. Yes, the gene test is practically the same as her sibling, but the rest of tests are fine. Well, I didn't mention this, but since the sibling has developed the disease, and with the gene test tells you that potentially they can develop the condition, but sometimes we don't know, but gene tests are available. We have 2 siblings. One of them has ASD, and they did this gene panel, and they found sort of altered genes from Wilson's. There's not a single question. Basically, we have these gene tests, and we might not know what to do, but the consensus is to try to treat from 3 to 5 years old, and we start to treat with zinc in Wilson's, because that sort of avoids the condition to progress. But we have issues with daily intakes, gastric issues, and sometimes it depends on what drugs and tests we have at our disposals. In France, basically, there's this DPA, and we also can think about the Wilson. But as I said, it depends on many aspects, but we can start depending on the form, the clinical form. We decide on various aspects, and then we take into account the tolerance as well. Just a question. Maybe the exchangeable copper would help us to assess the REC, basically. Yes, it would be positive when the child is 3 years old. Yes, DDAC, my son, has been diagnosed. The exchange copper he was not tested on that, and the daughter hasn't been treated yet. Only the gene test, and DDAC, my son, basically was given DPA, cupripren, I think, and there was some inflammation in the liver, high transaminases, and they started doing that. You mentioned long-term effect of DPA, very quickly, what are the side effects? I've heard about some skin involvement. Could you tell us about the long-term effects to identify them? Well, when they reach adulthood, basically the first treatment when there is impairment of the liver, there's penicillin. When they reach adulthood, because the cupripel, basically what it does, it depletes the overload copper, and the other drug basically does act as a barrier. We can, at adulthood, we can go on with the cuprin, because maybe there is not such good gastric tolerance, but you know, the elastosis, you know, there is this aged aspect in the skin, in some areas of the skin. But we think in some published studies in the literature, it might not be enough to avoid the copper overload in the liver. So in these hepatic forms, the results with the Wilson, in the long term, I mean, might not be so promising as with cupripren or with trientine, which is the sister of the cupripren, basically, and that seems to have a better long-term tolerance. So you can play around with these drugs, and you do some test and trial. If it's not working, you have to step back. We can switch among them. But I think at the beginning, they have to get rid of this overload of copper. Thank you. Good morning. I'm Wilson's patient. 38 years ago, I was diagnosed. About 4 or 5 years ago, they detected some angiomas in my liver, and I've been told that they are benign, so they will not have any malignancy, but angiomas, and I'm talking about what the doctors told me, they are benign. We need to do a follow-up with ultrasounds and see the size, if they grow or not. But my question is, like, angiomas and Wilson's disease, are they related? Well, no. Well, angioma is very frequent in the general population. They tend to be benign, and some people have angiomas. We find that with ultrasounds, and a small percentage, very low, but most of them are benign with a normal follow-up and with ultrasounds. Good morning. José Antonio Pedre, Wilson's disease patient, 45 years, and I presented with neurological features, and this is for the families that are here. This is just a message. In France, they are working with multidisciplinary teams, such as here in Valencia, but unfortunately, not many hospitals are doing that with the multidisciplinary hospitals, Valdebron, El Clinic, and Madrid and La Paz. But we have to go to those hospitals. But if we have a consultant that has only 5 minutes because they have 100,000 patients, and if we are poorly diagnosed and poorly treated and managed, basically we need to go to move to and be referred to these reference hospitals. And that's my message to the families. We have all the right to be seen in reference hospitals in Spain. And they pay all the traveling expenses and stuff. You have to apply for that. Multidisciplinary reference, so hepatologists, gastroenterologists, and ophthalmologists, neurologists, all the different consultants that can see us in the same department, and they can work together in the same department. So we have all the right to have all the visits in the same day. So that's what they do in France.
Thank you for your question. In France, we have the luck to have several reference centers for rare disease, and this allows us to catch the patients, because practitioners, when they know us, they address us, the patient. But there are also hepatologists or doctors in France, even neurologists, that keep one patient because he has Wilson disease, they want to keep for him. And sometimes we catch patients who had the same treatment for 30 years with elastosis and everything. So it exists in France, but it's true that the presence of National Reference Center allows us to have expertise of this disease, and with a multidisciplinary care. But it's a luck, of course, and we are conscious of that. Thank you.
Yes, I just wanted to reply to the colleague. I'm a public health professional. We cannot do that change. You need to push for that, you patients, families. Otherwise, the system will not change, because we've always done things that way. And obviously, we need the patients' organizations need to push, and that is key. We have patients in our hospitals that they are seen by neurologists, but the gastroenterologists don't know anything about them, and that's unacceptable. I think if we have these reference centers, that's key, but we are learning with you. I've learned with the patients that I've followed up, and I continue learning from them. So this site where you, having this neurologist, having a group, that's important. But in Spain, there is high variability. Some people cannot travel 3 hours to a site or a hospital, but nowadays, new technologies, we can do video conferences, and many things can be done. We've learned about that during the COVID pandemic. So I think at present, maybe some cases with more cases, La Paz, I think it's just a question that the organization can collect all that information, and sometimes I get cases that are referred by you. Yes, a patient can has some doubts, and Zoe also gets those visits as well. They call you, they send you an email. We can do these distance consultations as well, or visits. Microphone, please. We don't have a microphone. We cannot hear the person, I'm afraid. Apologies. Please, could anyone hand the person a microphone? A microphone, please. Yes, I sent all my... Yes, if we don't have a microphone, we cannot interpret, please. Well, this is the situation in Spain. Yes, the multidisciplinary teams, we have them in Spain, and we have them in La Fe, here in Valencia. Dr. Berenguer with El Clinic Hospital in Barcelona, a reference hospital. Ramón y Cajal, again, is another one. And doctors tell us, go there, please be referred to these hospitals, because they'll see you. And I think there are the means now to meet these demands. And if we are in a regional hospital, I don't know, in Elche or Guadalajara or Ciudad Real, small town hospitals with many patients and many conditions with aged populations, and overcrowded visits. Obviously, the physicians don't have the time to study Wilson disease patient and communicate and liaise with the lab. So yes, being referred to these reference teams, I think that's what needs to be done, so we can all have this special treatment. Even the blood tests. Blood tests are being performed now in Alicante, for example. So, yes, that's what I wanted to say. Well, I'd just like to ask the neurologists, do you always start with chelating treatments with the neurological forms, or do you start with zinc, or do you think that do the chelating procedure first and then deplete the copper, or shall we start with copper because they stay stable? So I would like to know the difference about that.
Because there is, to answer to the other questions, there is no randomized study to compare zinc and chelation on the neurological form. So yes, by use, we have the instinct that chelate the copper from the brain and eliminate it is more efficient than the zinc, which prevents the absorption of copper. But it's not a recommendation international. For example, in Poland, Anna Członkowska have a good experience of zinc, and it should work in neurological form, but it takes time. Zinc is appearing to work, but it takes more time than chelation. But maybe there is less increase of the symptom of neurological form with zinc than chelation. This is not good study, it's more experience. But in France, we have, yes, the experience that we have to chelate in first with dipenicillamine first and contraindication with trientine.
I'm telling this because I've seen some of these cases of paradoxical neurological deterioration, and when you see that, obviously you get scared of giving some chelating treatment, starting with a slow with slow dosages and titrating them up. That's well, I'm quite scared. But sometimes I feel, okay, if thing doesn't help us, do we switch to chelating agents? Do you believe that that's better? Otherwise, if there is the neurological damage will not improve if there's a long time that has elapsed.
Severe dystonia which doesn't respond and improve the under chelation even slow, we can follow this. Even if they are stable at the beginning, not a decrease, it's okay. But you see some patients that they decrease the neurological symptoms, even with treatment, and you feel that even if you switch for zinc therapy, it would be efficient. So you have to consider slowly, but as soon as the beginning of the Maladie, the liver transplantation, because it can be enough, and it depends on the severity of the kinetic of the symptom. So it's more case by case.
Hola, buenos días.
Right, good morning. I'm the mother of a Wilson's disease patient who started with neurological symptoms, 27 years old of age, and they worsened with the DPA. Then we switched to trientine. I didn't want to ask about treatments of Wilson, but rather about treatments that offset these Parkinsonian symptoms, rigidity, and all the rest. And I think that you've mentioned levodopa, and she's taking that, and it's improved somehow. But is there anything else that we can do to improve these symptoms? And I'm not talking about hepatic symptoms.
Gracias por su question. Is they tried treatment for Parkinson for your son? Yes? Elle a demandé s'ils avaient essayé le traitement du antiparkinsonien pour son fils. Ça marchait?
Si ça marchait,
Non.
Sí, hemos
We don't have, we have studied the treatment of Parkinson's disease. It doesn't work because it's not the same way of working with Parkinson's, so they don't work. But we have several treatments against dystonia, because Parkinson's syndrome includes slowness of the movement. This is more the physiotherapy that works. That's the best treatment for that, and regular activity. And for all this dystonia, with this can be painful with the retraction of the muscle, we have several treatments which can take orally. Yes, we have this, like amitriptyline or several treatments, but there is a lack of side effects that we have to check. The other possibility is to make toxinum botulinum. You know, the toxinum is the injection that you can make for getting younger. We do it in neurology for decades now against dystonia, because we paralyze the muscle and we can act against this dystonia. So this is basically the three kinds of treatment: medications, injection, and physiotherapy.
Venga, sí, la última.
Okay, the last question, otherwise we need to go for a break. Okay, this is a very easy question, maybe not the answer. This is for Eduardo about the exchangeable copper. Since you are a pediatrician and you're coming from France, where they started this, you have a long experience. We'll be talking, me and Antonio, about population screening, and we're thinking about how useful is the exchangeable copper fraction in the screening in the asymptomatic patient with relatives, or in the general screening. I somehow remember, maybe you can confirm, that in the validation studies there were no too many cases like that, or maybe asymptomatic children, where we do the test of the exchangeable copper, the full test, and see what the value is. In your presentation, I somehow understood there were 6 cases in the pediatric groups, very close to the general group, that didn't comply or meet this criteria. Do you have any cases on the validation initial studies, and what's your opinion? His father was asking our colleague here about the second child, the asymptomatic child, if the traditional profile of the copper metabolism is normal, the exchangeable copper results would be okay. So the screening would be done with the gene study of the sibling. Well, these are 2 different situations. In our case, unfortunately, we find false negatives, but we didn't have false positives. In France, we might overdo this a little bit, but in the high-level transaminase cases, this is part of the test, and for technical issues, the lab sends me all the results, all the copies, and we haven't found any false positive cases. So it could work. And all these cases of screening that we do for children, aside from the gene test, we do that with the exchangeable copper, and it works. But we haven't performed this cohort, but I like the idea. So a patient or a relative from patient that we want to confirm, but it's pre-symptomatic, no elevated transaminases. Yes, you're right. So until this study, we didn't have any cases, but we cannot say that this is 100%. This is a relatively efficient system, but again, I cannot state that this is 100%. Right, so I think that since there are no more questions, we're gonna take a break, 15 minutes. Please come back at past, so we will continue with our second session. Thank you.